For my Data to Wisdom project, I focused on reporting of injuries across genders in high school. So my clinical question was, does gender influence the rate of reporting non-fatal injuries versus serious injuries in patients who participate in high school sports? So looking at the data, I primarily focused on direct injuries in high school students because I do work in a secondary school setting. So what it gave me was the reported direct injuries, whether the injury was non-fatal, unknown, fatal, or serious. I did not consider any unknown due to the fact they were not reported in the final chart, and I did not focus on fatal due to the fact they could not be reported by the athlete due to the nature of the injury. It also gave me the sport, and I primarily focused on sports that contained both genders. And it also gave me the gender separating into each reporting group across the sport. The data that was missing was the length of an injury, so whether it was chronic or acute. To go along with that, it also did not give the classification of a non-fatal injury or what's deemed to be non-fatal. So I looked at this and I kind of figured out serious injuries were tears or fractures, while non-fatal were more likely to be chronic and strains. And then that kind of goes hand in hand with the type of injury as previously discussed. The data was used as a comparison of genders for reporting. So for example, regarding non-fatal, females had a higher reporting rate of non-fatal injuries versus males, while males had a higher reporting rate of serious injuries versus females. And then looking at comparison of non-fatal versus serious reporting, non-fatal and serious reporting did not have any statistically significant difference between them. Both of them were reported relatively equal in both genders. And then the databases I used to search for the further information that I needed to come to my clinical conclusion were PubMed, Medline, DOAJ, and NCBI. All of them are regulated by the National Health Institute, which is NHI. And then my search terminology used, I kind of separated it out so I could look at genders, then also just reported injury rates, and overall like how athletes report injuries. So the first terminology I used was gender disparities in health, to determine if there is a difference between genders in health, whether it be pain tolerance, how their hormones can change, how they perceive pain or an injury, and any other things that may come up, including psychological health. I also looked at overall reporting rates of injuries and how likely athletes are to report injuries, which goes along with the terminology athletes reporting injuries, so I can get more sports-based answers to correlate with the data better. I also looked at gender injury rate to determine whether there was like a difference in like how often each gender gets injured and what that could be the cause of, and I also looked at pain across genders. So one of the first things that I came across is hormones can affect your pain levels, and this shows in because estrogen causes more pain to be felt, as well as testosterone acts as an androgen pain blocker for men, and also having higher estrogen makes you more prone to an inflammatory response and a chronic pain response. So females typically have a lower pain tolerance than men, which can lead to them reporting injuries more likely and more frequently, as well as reporting non-fatal injuries more frequently than men. And if we place the chronic injuries into the non-fatal injuries, that can also be a reason as to why females are more likely to report their non-fatal injuries versus men, because they have a chronic pain that they do have a lower tolerance to. Another thing that was found is that the risk of mental health does play a role in pain levels as well. So those who are more prone to depression or any anxiety typically have a higher rate of reporting an injury that may not be as severe due to the depression and their brain chemistry kind of influencing how they perceive their pain. So for example, in research that I found, women do have a higher likelihood of developing depression or anxiety or most mental health illnesses, which can be a contributing factor as to why women have a lower pain tolerance and therefore have a higher reporting tendency of non-fatal injuries versus men. Across the board, two things that I found that do contribute into reporting injuries is access to care. So having access to an AT can change on how a patient reports their injuries, because seeing a doctor may lead them to missing out more on their sport or missing out more on stuff with a more severe treatment versus reporting to an AT who can help you work through an injury and give you modified participation, so that way you can still participate in your sport. Another thing along with access to care is access to medical knowledge. So this is kind of where the definition of like different grades of sprains come in, and whether someone thinks something is more severe than what it actually is, or someone brushes off something. So for example, concussions were used in the research I found, and a lot of high school students do not have the knowledge of what a concussion is and typically do not report concussions. About 50% of them do not report concussions because they do not know what it is and they do not think it's severe enough, which typically leads to a higher rate of severe injuries in those who do not report it because they're more likely to have the second traumatic brain injury, which can lead to more serious injury reporting versus non-fatal injury reporting. Along with that, fear is taken into consideration when looking at reporting injuries, because most athletes do have a fear of whether they'll be able to return to their sport, whether they will lose their starting position, or whether their injury can change how they play forever, or if it could be a career-ending injury, which does take in consideration the identification of reporting a non-fatal injury versus a serious injury. So putting this towards clinical practice and just some ideas to bring into it is that the severity of an injury is different for each gender and person. So like I said before, the hormones do contribute to whether something is more severe to the person versus a different person. So with women having a lower pain tolerance, what they deem to be a more serious injury that they would report, while it may be non-fatal to the medical professional, would most likely be less serious to a male due to the pain tolerance. And then same for person, that's what takes into your mental health and all of that. That kind of goes with individual biology, and background can affect your pain levels, so those two go hand in hand. And this also falls into pain tolerance being subjective across the board. And then treatment plans can alter based off the individual. So if an individual is more likely to have fear returning to their sport, you can develop a more graded return to play program where they are less likely to develop fear returning to their sport, or something to allow them to continue practicing so that way they can reduce their fear of losing their starting position. So some advice I'd offer to all athletic trainers in our clinical practice is that when looking at pain scales, you need to consider gender as well, for whether something may be an 8 for a female versus an 8 for a male regarding the seriousness in that due to the hormones as previously discussed. And then also acknowledging mental health when discussing pain. This is when an HQLO may be beneficial to help identify if there's any underlying reasons as to pain could be more severe for an individual versus someone else in the same injury. Along with this, also explain terminology even before an injury, so having discussions with your athletes about what different injuries are and how they can be serious even when not reported, and how they need to be identified right away so they do understand the gravity of injuries in certain situations. And then also recognizing fear when making clinical decisions and offering options. So with recognizing fear, allowing them to kind of gradually go back to their sport, or allowing like limited participation so that way they can still do stuff that they're able to do with an injury that does not affect the injury site or joint, so that way they can still participate with their team, which may actually benefit mental health and reduce pain. And so they also don't have the fear of losing their position or losing their spot on the team, which can all be beneficial towards our clinical practice. And then these are my references.